right, good afternoon, everybody. My voice is suffering today, so I may sound a little bit weird, but everything's okay. Um, Today is SEVA VentRounds, October 17, 2023, and we're going to talk a little about work shifting. This is a common topic that comes on our discussions, and I thought that we could review today. The disclosure is there's no endorsement of any mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. Here are the disclosure for myself and for Rob. Chatburn, we're both your hosts today. The ground rules is please keep your microphone muted, at least for the sake of the recording. Although, if you want to chat or make a comment, then use the chat function, or you may unmute yourself and make the comment. We're happy to hear and interact with you. Just don't keep it open all the time. There are CMEs and CRCs for those attending. If you're a respiratory therapy, do enter your chat in the chat your name, and at the end there's going to be a little evaluation that will come in that you need to complete so that Ryan can provide the CRCs. So let's get started with some of the comments. This is a graph that Rob created for a paper that was written in 2020, in which we were describing the concept of ventilator of work shifting. And in this example, what you have is a volume controlled breath or flow controlled breath. And what you will see is flow, volume, and pressure. And on the pressure waveform, you see the manifestation. The first step up is the manifestation of resistance. Then the slope is the manifestation of elastic load. And then the breath ends and it goes back in the ideal environment, straight down to peak, and it stays there. And in this case, there's no evidence of any PMOS. And so all the work of breathing, so the pressure and the volume delivered because of what happened is the work is being done by the ventilator. However, in this mode in particular, if the flow is being delivered, so it's volume controlled, and there's the presence of PMOS. So the PMOS will subtract, in this case, it's 3 centimeters of water from the pressure that the ventilator is delivering. So both of them are acting at the same time. So the ventilator doesn't need to use as much pressure to deliver that amount of flow, and you're going to see this deformity on the waveform. However, there's still work being performed by the ventilator on the patient if the pressure is above the baseline. But this deformity tells us that there's the presence of PMOS. So there has been some shifting from the pressure that the ventilator was delivering when it was passive to the patient. If the effort is even higher, like you see here, the shift is even higher, and you can see that in this case, the pressure that the ventilator was delivering is actually now going below baseline, below peak, which to us tells us that there is actually now work done on the ventilator. Rob, do you want to talk a little bit more about this?
There's not too much more to say except that PMOS can happen at any time, right? It could happen before the trigger, during the trigger, after the trigger, and after the cycle. Anywhere it can happen. It can be any size because PMOS is basically a random function.
And so this is important to see it this way. And so, and we're going to talk a little bit about how this looks on pressure control modes. But this is probably the easiest way to conceptualize how the shift occurs between what the ventilator is doing and the patient is doing. So when you hear us talk about work shifting, we talk about that is when P-vent and PMOS, sorry, I gave this lecture in Spanish, so I use I, which is and. So PMOS and P-vent are active at the same time. So one portion of the total ventilatory work is done by the ventilator and the other by the patient. And actually, it's a type of measure that we can do. We can see how much the ventilator is doing, how much the patient. This is all often in clinical terms used the word assistance. How much is the ventilator assisting patient or not? And so we have come to now in literature, we use two terms. One is over assistance, where we're giving too much P-vent for the PMOS, and we're doing this in an unintentional statement. So not sometimes we do this intentionally. We give much more and we over assist intentionally. But over assistance in general now has come to mean this situation in which we're giving more support than the patient needs, and that leads to less activity from the diaphragm, which could have the dire consequence of atrophy. And then you have under assistance, in which the PMOS is the main one, and you, again, not intentionally, are giving very little P-vent. And so in that circumstance, the patient is doing most of the work. Rob?
Oh, that's a good way to put it.
Okay. All righty. So that's the general term. So now we're going to go into a couple of examples that may help you. Patient work shifting equivalent. Yes and no. So Albert is asking, is under assistant and patient work shifting equivalent? And in reality, no, because this one over here would be called, there's work shifting. But I think under assistance refers to this one, which what we have called severe or extreme work shifting. And in literature, you'll see that I really don't know where this term came out. And actually, we wrote an abstract, and it was the first abstract to describe the term, I mean, in literature, with a graph of severe, of not air hungry, flow starvation. But that's what this refers to. So severe work shifting equals flow starvation, which equals in our book under assistance. Yeah, I would say that this is just a little tip of the iceberg of what we know in terms of where does the work shifting occur, if it occurs at the beginning or at the end of the breath or during expiration, and what's the total, because there may be one breath that has a lot of work shifting and the next one is completely passive, and then which one is which, right? How do you go to terms with that? I do not have the knowledge to expand further into this, but I think this is a very exciting area of what we're doing. So here's the first example. This was a courtesy of Dr. Ravi Krish. He sent directly to me. But this is a good case of a patient he was taking care of, and I'll leave you first to read the waveform, and let's start by the tag. So if you want to test yourself and just enter on the chat what you think the tag for this mode is, and I put everything. I didn't hide anything from this. This is like he sent it to me. All right, I start seeing the entry of the tags coming through. And then remember, this is essential so that we can read appropriately what's going on. All right, so I see that the team in general has chosen that this is VC-CMVs. And what this stands for is that we have agreed that during inspiration, what we're controlling is volume control. So what we're controlling is the flow. And so essentially what we would be expecting here is that the pressure during, I love it, thank you, Ariel, during inspiration, you would expect the flow to be controlled. So in reality, for this patient, you would expect the flow to look as a square waveform. However, what we see here is a sign conformation, and it's very regular, almost regular amongst all of them, but there's small variations across them. We do so. So the first question is this actually volume control, or is this pressure control? And what we're seeing here is a lot of work shifting. So Ariel Garnero, knowing that this ventilator does funky things if you activate something else, says, well, perhaps this could be VC-IMV type 4 DD. And what that stands for is that in this ventilator, if we activate a thing called flow adaptation, and I think that in this ventilator in particular, it was not even called flow adaptation. It used to be called, what was the name? It was just a little square like this with some dots on the top like that for adaptive flow. But it looks pretty suspicious to me that this patient is actually using the dual mechanism here, as I see it, just because of the sine waveform. And in general, this ventilator at that time didn't have the software that hided the things. So I think that it's simply that the patient is taking a very deep breath during inspiration, and it's actually converting from initially volume control to dual. So it's changing from volume to pressure control during inspiration. Roberto?
Yeah, it's difficult to tell, but I would guess that that's probably what's happening.
Yeah. And that is because the patient is doing a lot of effort. We're going to get to that in a second. But you can certainly see that the flow looks in a sine waveform instead of a square waveform. Now, I can tell you that for some ventilators, the ventilator may modify how the flow waveform, and the servo U is one of them that does that. But to my understanding, the servo S didn't do that before. It was until they did the servo U that they started creating these simulated waveforms. So I would say that this is actually most likely volume control IMV 4.4, and what you're seeing here is the dual setting being activated on the patient. That's what I would suspect. But it's a good discussion to know that this ventilator can have both, and it all stands by you pressing what is called flow adaptation, which is this icon that I drew up here when you're on the settings. And I'll show you an example in which we didn't press it in a second.
That depends on the software, Eduardo. If that's an older ventilator,
Yeah.
It's just by default, and you don't even know it's happening.
Exactly. Yeah, because it could be set up in the past, right? And you wouldn't know. However, regardless, this still will show you a lot of items. So if we think about what is the load during inspiration, let's go with inspiration first. Is it PMOS? Is it elastic, or is it resistive? And Victor immediately jumps in and says, this is pure. And Rana too says, this is pure PMOS. And we agree with you. I mean, this patient is using all PMOS, and we're going to go into more detail as we talk about inspiration. But you can see the pressure waveform, how it dips. The patient is triggering here, and we know that the patient is triggering because it changed color to pink, and because the pressure drops during inspiration. And then during inspiration, and we know it's inspiration because the flow goes above baseline, you can see that the pressure is actually, in this case, even below PEEP. And the PEEP is below for another reason. We're going to talk about that. But there's definitely PMOS during inspiration. And then during expiration, which is this period over here, what's the load? Elastic, resistive, or PMOS? And Rana jumps up and says it's PMOS. And absolutely, in essence, seeing here all about expiratory PMOS. And that actually explains why the pressure during expiration looks even higher than inspiration. And it could be one because of work shifting, But number two, PP set at 4, and this probably looks, I cannot see the graph here, but I would say that if it's higher, it's probably because the patient is exhaling, actively exhaling on the circle. Roberto?
Yeah, this patient is basically panting, right? He's panting with a short inspiration and a short expiration, and the ventilator is completely out of sync with him.
Yeah, it's kind of sad. So if we look at the trigger, so now we go to the patient ventilator discordance, there's a lot of PMOS. So definitely there's patient ventilator interaction. So let's talk a little bit about the trigger. If we look at the trigger, we see that it triggered by flow, and it changed from the patient exhaling to inhaling rapidly. So the patient went whoop and started, and you can see how the pressure drops, and then eventually the ventilator starts pressurizing, and even though it starts pressurizing, the pressure drops below baseline. So what do you think about this trigger? Is it normal, early, late, false, or failed? Put it in the chat. Have no fear. Yeah, and the people are putting normal, and that's actually likely the right answer, meaning what you're seeing, this dip, which is what you would expect to see on somebody with a late trigger, is sometimes you can also see it when there is evidence of very high workup breathing, meaning the patient is doing so much high workup breathing that the ventilator, even though it's trying to pressurize, it can't meet the demand of the patient. So I think that it's important for you to consider that this could be late, as Ariel highlighted, and see if your settings are appropriate in terms of threshold and whatnot. But this is the waveform up here would be one that you would consider that this is late, but you can see that it's triggering right immediately as it crosses the zero flow, and so that makes me think that it's normal. Roberto?
I would say it's
Yeah.
late because look at where the effort starts by looking at the expiratory flow curve. If you were to draw a PMUS in there, how would you make it look?
Well, you could argue that it starts right here where I'm pointing this out. But the flow waveform, and I mean, granted, this is a picture of the screen, so it may not be perfectly aligned just because of the way that it was taken. But from the flow waveform, if I was gonna say that where it started, I would say that over here. So I think that there's a discordance from what I'm seeing on the pressure waveform and what I'm seeing on the flow waveform. I would say that probably here on the pressure waveform, and I think that you would agree with that. And I think on the flow waveform, I would say probably over here. Do you agree with that or not?
Yeah, it's kind of odd looking for sure.
It is odd looking, but so I think that I mean I agree with you, Rob and Ariel, that probably late but likely normal. I don't know. I mean, but this is something that you want to do. This patient, this poor human, is working like there was no tomorrow.
Well, the
And I
thing
agree
is,
with you.
Eduardo, it's normal from the standpoint there's nothing you can do about it because the flow sensitivity is probably set as well as it can be. But it's not normal from the definition of what late trigger means. It's the ventilator's response relative in time to the patient's effort. And it's late. There's no two ways about it. And the way you could fix it, or the way you could tell, is if you had an ECG or you put a NAVA catheter in there, right? And you would know.
Yeah, absolutely. That's those are so you're talking about, and I love this, Rob, is, well, if we had an EMG on this patient, right? Or if we had a esophageal catheter on this patient, and I sometimes suffer, and I saw a discussion between Miguel and Ariel recently on Twitter, talking about the possibility, and we had, I think that Ariel was putting a patient that we recently had in which there was no signal, no EMG signal, but the patient was generating pressure with the respiratory muscles. And so if there was an esophageal catheter, then you would see the truth perhaps would be this the esophageal pressure that you would see versus the EMG that in the case that we were talking about. But in general, what you would take in hierarchy of which one tells the truth, it probably starts with the EMG, followed by the PIMA, the esophageal pressure in a normally breathing individual without diaphragm paralysis and without other things. That would be probably the hierarchy of truth. Although as we have seen, this can be a false statement. Rob?
I've seen a patient with a Nava catheter in, a paralyzed diaphragm, triggering the ventilator with just the accessory muscles.
Mm-hmm.
Slow triggering with accessory muscles.
Yeah, that was the case that Ariel was putting out there, in which we exactly what you just described.
Yeah.
So
it happens.
Just
Oh, we lost Eduardo. Unfortunately, I can't change the screen. It's coming from Eduardo's computer, so we just have to wait for him.
inspiratory period is from here to end here. So this patient was set up with an inspiratory time that includes a pause, an inspiratory pause at the end of the breath. And you can program those on the ventilators. So during inspiration, is it normal? Over assistance, under assistance, which, as you said, and we're still working on this, but it's severe work shifting, essentially. So yeah, Victor, right on the money. So you see that during the inspiratory period, and it's matching so nicely with the before the inspiratory pause. You can see that the inspiratory period, there's essentially no pressure or minimal pressure being delivered to this patient. But this may be one of the benefits of flow adaptation, that at least the patient is getting some pressure as they're being ventilated with the machine. But this is severe work shifting. And you see almost no support during the breath. And then what about the cycle, team? Yeah. So the team's starting to recognize that there's a late cycle, and yeah, absolutely. So you can see that there's this pause in which the valves close, and now the pressure goes all the way to the sky because the patient is either breathing, exhaling actively, and I think that it's because it's exhaling actively, because there's difference on the heights of the pressure waveform, and it's trying to exhale through here, and then essentially expiration, the machine cycles, and then the patient continues to exhale and then takes a breath in. So this pause has generated a late cycle. And then we talked about expiratory work. Rob?
Nothing more to add. That's exactly the way I would see it too.
Yeah. So this is a pretty darn horrible event. The other thing that I was thinking, that it may also make us suspect that this is a patient that has this flow adaptation, is that the volume seems to be changing from one breath to the other. There seems to be these little steps between them, so that makes me think that may be the case. And there seems to be a leak also on this patient with the exhale volume that they're getting. Oh, great.
I'm not sure
so Ariel, huh?
I was going to say, under these conditions, I wouldn't call that a leak. I think the patient is simply
Well,
exhaling
we don't know.
different amounts of gas because he's panting. Sometimes he exhales a lot, sometimes he exhales a little. So it's hard to say. I wouldn't call it.
It's possible.
Yeah, I think that's really what's happening.
You're getting cut, Rob. Do you want to turn off your camera for a second?
Okay. I was just
Go
saying, it's
ahead.
difficult to tell if it's a leak.
Yeah, I mean, it could be a leak, or it could be that he's exhaling differently, but it continues to be about the same amount for each one of the breaths, except this one.
Yeah.
So I don't know if he's leaking because he's exhaling against pressure over here, or if he's exhaling different volumes. I cannot tell. But I think that that's in the differential, right?
Yeah.
So the question that Ariel asked is, uh, what mode would be the best for him? And I love the comment of Miguel. In the scale of modes, if we had to choose all the modes on the universe, of the 590 modes out there, or 795, it was 795, sorry, 795 modes, which would be the best and what would be the worst? And Miguel said this would be the worst, volume control. And probably this is not the worst because this one at least has flow adaptation. So I would think that there would be volume control, true volume control, and then you would have this dual mode. So the dual is a little bit higher on the hierarchy than volume control for these very high PMOS. And the majority of you are asking, well, perhaps for this patient, it would be to liberate, stop controlling and support the amount. And so to modes that could go over here is PC-CMV, perhaps as the first. Yeah, that's what I would think. PC-CMVs. For high work of breathing, there's no good mode, but you probably would have to try to. The first question that you would make yourself is, what is your goal here? And I think that if you start by thinking on the goal and you think that the goal is safety, then absolutely there's no mode that will achieve this. If you're thinking about comfort, then you have a series of options that start with pressure control, CSV, S, R, and whatnot. So great points, Ariel and Raquel and Albert. Very good. So Albert asked, well, how does liberating the flow helps? Well, it's not that you liberate the flow, it's that you start supporting the patient. So you would change to a pressure support environment, Albert, to allow the flow to descend. Rob, you want to try? Let's see if your connection is better.
Yeah, I agree 100%. Liberating the flow simply means to let the patient have as much flow as they want while still providing some inspiratory pressure support. And as you say, that may be a good thing if you want comfort and the tidal volumes aren't excessive, but it may be a bad thing if the goal is safety and they're breathing 15 mLs per kilogram.
And this is a key item. I want you guys to recognize that this is a showstopper. You don't go to the bathroom even if you have not gone in a month. This is one of those that you have to stop and deal with it and decide, is my goal safety or is my goal comfort? And depending on what your goal is what you're going to do for this patient. Ryan asks us, what level of pressure support is the patient getting in this situation? If we, and I presume, if we switch him, Ryan, or right now on this graph? Right now. So right now, the patient is getting very little amount of support actually during inspiration. And then when he's exhaling, he's working against the ventilator. So essentially, when the patient is breathing in, is getting nothing or very little, practically PEEP. And then during expiration, the patient is exhaling against a closed valve. And so you can imagine the work of breathing of those respiratory muscles.
And this patient's probably working harder than if you just disconnected him from the ventilator.
Right, exactly. So the question here, and that's why the goal-directed mode selection is key here. If you don't have clear what your goal is, if it's safety, comfort, or liberation, you may be either paralyzing a patient that doesn't need it or giving a patient a pressure support with large tidal volumes and injuring their lung. So I put this one, this little slide. I know that we're over time, but I'm going to change to this one just so that you can see it. This is a patient today. You can see the date that we took care of. And just for the sake of it, so that the teams can see the difference. And that's why I think that the mode is VC-IMV 4 DD. Just look at the difference on this patient. Also look at the difference in the pressure between this one and this one over here. This is a patient that had that was on pressure support with high work of breathing. And you can see we changed them to volume control, and this was true volume control. We turned off that flow adaptation. So this was definitely VC-CMVs. There is no question about that because I was at the bedside and Raquel helped me change it. And again, you can see that during inspiration for this patient, the waveform doesn't look beautiful. It doesn't look like a square. But that is because this ventilator, when you see this little item here, this icon that I'm putting in a circle, and we know this just because we had a conversation with the engineers. The waveform is a simulated waveform of what the circuit would be, the circuit is seeing in terms of flow for this patient. And Rob, please correct me there, but you were present on that. But this is a simulated.
What the difference is, you can tell at the very beginning of inspiration, there's a little spike in flow, which you would not see if you didn't have that compensation on. That little spike in flow is the patient sucking gas out of the tubing. It's a little bit of flow and a little tiny bit of volume. It comes from the circuit. Whereas if the circuit had zero compliance, that would never happen. And so that's why you're seeing it.
And so this waveform, in reality, what the ventilator is delivering is a square waveform, but this is the graph that you're going to see here.
Right.
And that's why it's essential that you learn what the tag is for the modes. If you don't know, if you didn't know this, then you would be completely confused with what is happening. Well, you can see that in this patient, when we switch to this mode, just to show the effect, as the patient is not getting the volume, you can see how it starts work shifting. I mean, the pressure starts going below and lower, even though at the 60 cc per kilo that we wanted to force the patient to get. And so, there was also a late cycle, and you can see that here, I mean, it was failed. And so that's why the pressure goes up on this patient, because the I time that we said was inappropriate. Again, very low level of disease. We cannot extubate this patient because of a neurological injury at this time, but this is how VC-CMVs work shifting looks versus VC-IMV for dual, so dual work shifting. And so you can see why on this graph of the worst mode, this would be definitely worse because the patient is putting themselves at risk for pulmonary edema. And this is just unsupported work. They're working against a closed, against flow that is not increasing, versus this one, in which at least the ventilator is liberating the flow and is maintaining the pressure at a given level. Albeit you're not going to have control over your tidal volume for that group of patients. So really a good contrast of two modes showing work shifting, severe work shifting or under assistance that need you to stop and deal with it. Now, some people ask me, well, how, if I put it on pressure support, and here's the pressure support waveform for that same patient, and you can see that we're giving very little level of pressure support. So now this patient is in PC-CMVs, And you can see that the patient is still doing a lot of effort instead of having this exponential decay on the waveform. All of this is work that the patient is doing. We dropped the pressure support a lot. We were almost at CPAP. And you can see that the patient is getting very large tidal volumes, which on the case for this patient, we decided that this was not aligned with the goal. And we said, well, what's your goal? And we decided that the goal was safety. We did measure a POC on this patient, and the POC, when we did the measurement, was 22 centimeters of water. And we said, this is too much for this patient. This patient, even though we're giving some support, if we give her more support to get rid of this POC, she would get larger tidal volumes and the lungs are very injured. So we decided to sedate the patient and deal with the issue that the patient was having. So there was not a good mode for that patient. So if we try to limit the tidal volume, we hurt the patient. If we try to liberalize, the patient got very large tidal volumes and unhealthy tidal volume. So that's why we decided to then use medications to depress the respiratory centers and get her back into a more appropriate values. So here are the CMEs for the CCF caregivers. Please take a picture. Ryan has put in the RT-CRC valve form. Please, this is with all love for all our respiratory therapists. Take and use them. For all of you on Twitter, send me your waveforms. Send them to Ariel too. Sometimes she shares with them. I love to see the discussions. Send them via email. And all the prior episodes are on this QR code in the SEVA VentRounds on YouTube. Again, thank you very much for your time. You guys are awesome. Really good discussion. Have a great day. Thank you, Rob. Thank you, Ariel.
Bye-bye.